I think I want to talk about the basic areas of the skeleton first. The axial skeleton is the head, the spine, and the sacrum coccyx, and then also the rib cage. That would be called the axial skeleton, whereas the appendicular skeleton would include the scapula, the clavicles, and then the arms hanging off. Also the coxal bones, and then the legs would be called appendicular skeleton. In the skull, I'm just going to give some of the basic bones in the skull. I'm not going to get real detailed with it. But anyhow, there are several bones in the big bones in the skull called calvaria and cranium. We know cranium means helmet. I believe calvaria means the same thing. Calvary, you've heard of the hill of Calvary. It was the place of the skull, Golgotha. You might have heard that in some history. The bone in the front is called the frontal bone, and then there is a coronal suture that separates the frontal bone from the parietal bones. Going down the middle of the skull is the sagittal suture, and the sagittal suture is what separates the parietals. And then in the back is the occipital bone, which then there is a rhomboidal suture, or a squamosal suture. Actually, excuse me, it's rhomboidal, and then the one that separates temporal from parietal is squamosal suture. There is an ear hole that you can notice. This is called the external auditory meatus. The face is made up of the maxilla. That's the biggest bone in the face, I think. And then we have the mandible. Hola. The mandible, the chin part is called the mentum. And notice that there are a couple of holes on either side here. These are what give the opening for nerves and blood vessels to come to the face, the mental foramen. The jaw, or the mandible, also has what's called a ramus, and then there is a condyle that articulates with the bottom of the occipital bone, and this is what, actually I said that wrong, it's the temporal bone, because this makes the TMJ, temporomandibular joint. And some of you might have had TMJ problems, TMJ pain right in here. And there is a very delicate disc inside of this joint. What I find as a chiropractor is oftentimes misalignments of the neck refer pain into this area, and a lot of times adjusting the neck, correcting the subluxations in the neck will help reduce this pain. I'm not saying that TMJ pain is not real, but a lot of times it seems to be referred from the neck. The floating bone in the neck is called the hyoid bone, and it's important for attachment of some of the muscles in the neck. You can see it kind of right here. It's the only non-articulating bone in the skeleton. All the other bones in the skeleton articulate with other bones. We have teeth that are anchored very deeply into the mandible and into the maxilla. The cheekbones are called the zygomatic bones, and then as they move backward to protect the muscles of the jaw as they insert onto the temporal area, this is called the zygomatic process. The bone that overlies the nose, these are called nasal bones. We have lacrimal bones, ethmoids, and then if you look deep into the eye sockets, you can see the sphenoids. And the sphenoid is probably easier viewed from inside of the skull. It kind of looks like a bat wing. And on the inside of the skull, this is where the sella turcica, the place where the pituitary gland sits. In the ethmoid, which is kind of in the front, there is a little plate area with holes in it, and then there's a sticking up part called the crista galli. And this is where the falx cerebri attaches to separate the lobes of the brain. The brain is compartmentalized down the middle, and in the back, the cerebrum is separated from the cerebellum by the tentorium cerebelli, and then there is also a 3-layer system around the brain called the dura mater, arachnoid mater, and pia mater, and then there's a cerebral spinal fluid which insulates the brain. So we have quite a bit of insulation and protection for the brain. What happens a lot of times if you get hit in the front of the face though, it causes what's called a contre-coup concussion, and the brain will smash against the back of the skull and actually damage the occipital area in the back of the skull. So you get kind of an opposite effect like that. A lot of people who box get brain damage. Right now a big issue in professional sports, especially professional football, is how many times does a quarterback get hit? Do you see concussions as an effect of that? I think one of the big ones that's been in the news is the Chicago quarterback from back in the 80s. I can't think of his name right at this second. I'll think of it in a few minutes. The mastoid process extends downward. There are several different regions of the spine, and I'm going to turn it back around this way so that you can take a look here. There is the cervical spine, the thoracic spine, and the lumbar spine. There are typically about 7 cervical vertebrae, about 12 thoracics, and about 5 lumbars. The cervicals have a transverse foramen, and that's what allows the vertebral arteries to go up through the neck to help supply the circle of Willis. There are also some carotids that help give some of the blood supply for that as well. The thoracic spine, notice right here at the top, the spinuses project almost straight backward, but as you move downward, they kind of shingle quite a bit. You can get some cervical vertebrae that have ribs, and sometimes you can get that in the lumbar, but typically the thoracic area is reinforced with ribs. Remember this, that when you have a bony cage, you've got high stability right there. And then when we move into the neck and we've got a 12-pound bowling ball for all practical purposes at the top, if you get into an accident and this whips back and forth, it's pretty easy to see that all the stress goes to the base of the cervical spine, right where it joins into the very stable area. And so this is what we see a lot of times in people that have car accidents, is a problem in the lower cervical spine, which is C6, C7, T1 nerve roots. In an interesting way, C5 and C6 go to the thumb, finger, middle finger, C6, C7, C8, and T1, lateral part of the hand. So a lot of times it's easy to see that if there's damage to the lower cervical area, like in a car accident, then a person can actually have hand numbness to go along with it. The one that's most involved with median nerve is the thumb and the index finger. Anyhow, I see quite a bit of this as a chiropractor, and slowly this heals after an accident with chiropractic care. And it probably could heal without chiropractic care, but a lot of times you start to get fusion and bony growths called osteophytes, which can cause a lot of problems later in life if you don't get care to keep that mobile and healthy. The same thing is what happens in the lumbar spine. I want to talk about the biomechanics there for just a minute. The hips are highly stabilized, and so because the hip structure is highly stabilized, when you move out into the lumbar region, there's muscle holding that, and there's some ligament low, but once again, you get a big stress point at the lower part of the spine, so the L4, L5 area is a big risk area for people. And in humans with the upright bipedal posture, this is one of the most common low back problems. It does respond extremely well to chiropractic care. As some people have said, this is the bread and butter of chiropractic. 80% of all people will have low back pain at some point in their lifetime. As the sacrum, as we continue down from the lumbar spine, we go to the sacrum and the coccyx. Because the coccyx is intertwined muscularly with the anus, it is easy to see how that if a person fell on their coccyx and broke this, that going to the bathroom would not be a very pleasant experience, because everything affects everything down there. Also in the female, notice that it's this opening right here where I'm putting my hand. This is where the baby has to come out, right through there. This is not a female. You can look at the pubic pubic arch here, and it's got a real acute angle. That indicates male. Female would be a broad, obtuse angle, something like that. One of the things before I leave the vertebrae for just a minute, the discs, intervertebral discs right in the middle, are oftentimes what swell. And since the nerves come out of these holes in the back, if the intervertebral disc swells, and it puts pressure on the nerve and causes pain, dysfunction, wherever that nerve travels to. And in the low back, it would be down the leg and into the hip, and low back all the way down to the big toe. So that's another interesting thing that we're learning too, is that some of the nerves, especially like the sciatic nerve, they're 3 feet long. It's a pretty long nerve. They're just bundled and rebundled and sheathed and protected. A sciatic nerve in an adult might be as big around as your thumb, going down your leg and the side back of your thigh. Let's go back up and talk about the shoulder girdle first. Then we'll go to the chest, then we'll go to the hips, the legs, and then the feet. In the shoulder girdle, the clavicle is what connects the sternal manubrium, the sternal area, to the acromion process of the scapula. Notice that the clavicle is an S-shaped bone, and the articulation of the scapula with the clavicle is called the acromioclavicular joint, the AC joint. So a lot of times right now, football season has started up, you hear of a football player falling on their shoulder, they've got an AC separation. What would happen is if I stabilize the shoulder and then kind of gently pull down right here, I would feel far too much translation in this joint right here. It could indicate that there's a separation there, and things like that probably would require a surgical repair. Rehab probably would not fix that problem. Let's go to the scapula. This is called the spine of the scapula here. There's a supraspinous fossa, an infraspinous fossa, and then there's a subscapular area, the part that articulates with the thoracic cage. This is called the glenoid fossa, and this is what articulates with the humerus. And there's a labrum, there's a cartilaginous lip that extends outward, and it makes kind of a deeper socket so that the head of the humerus, I may have said femur, I didn't mean to say that, the head of the humerus can fit into it. Now, let's talk about a practical application of this. If you're laying on your back and you're doing bench presses like this, and you've got this bone pressing that direction right there, you're not even pressing into an area that is being reinforced by bone. You're pressing into a cartilaginous labrum, into a cartilaginous lip. So I see that a lot of times with people who have lifted weights, 200, 300, 400 pounds, way too much weight. They have frozen shoulder syndrome after they get old. They wear that thing out. This is the humerus. This is the head of the humerus. This is the shaft of the diaphysis, and then this is the distal end of the humerus. You can see that there is a rounded area called the capitulum that is where the radius articulates. Then there is a pulley-shaped trochlear area where the ulna articulates with the humerus. There is also a groove right here between the greater and the lesser tubercle of the humerus, and there's a bicep tendon that goes down through there. Remember, the bicep is what helps to flex the forearm. This, by the way, is a tuberosity on the radius that allows for flexion of the forearm. So one of the chief actions of the biceps muscle is this right here. Actually, it is twofold. The biceps flexes and supinates the hand. So this would be, that would not be supination. This would be supination. This is anatomical position when we stand with the thumb facing outward. That helps us keep everything straight, because when we go into pronation of the hand and wrist, what you notice is that the radius crosses, and it's hard to keep up with what's medial and lateral. But if we put the hand like this, then we can easily see that the thumb is lateral, the radius is lateral, the ulna is medial. Now, in the wrist, there are a number of bones, and hopefully I can get all of these correct. On the bottom level is called the scaphoid, and lunate, triquetrum, and pisiform. There are 4 on the bottom row of the wrist. And then the top row, I believe it goes in alphabetical order. I believe it's trapezium, trapezoid, capitate, and hamate. I believe that's how it goes, and I'll correct it in the video. I'll write it in there if I didn't get it right. You can always remember that there's a hook on the hamate. So when you're looking at a hamate bone, if you can kind of flip it and see a hook on it, this hook, by the way, is what helps to create the carpal tunnel between the trapezium and the hamate. There's a little ligament that goes under there, and it's the median nerve that extends under there that gets compromised and gives people carpal tunnel syndrome. A true carpal tunnel syndrome will be an impingement here. A lot of carpal tunnel syndrome can be, or thought to be carpal tunnel, can actually be a problem from the neck. At the end of the ulna and the radius, there is kind of a styloid process. Stylus means pencil. That's kind of a key feature. In the hand are the metacarpals. There are the phalanges. On the fingers, there are the proximal, middle, and distal phalanges. And on the thumb, there is the proximal and the distal phalanx. Remember, the thumb and the great toe only have 2, all the rest have 3. All right, let's go to the hips for just a minute. In the hips, we have the coxal or the innominate bones. This portion is called the crest, and then this is the anterior superior iliac spine. As we go down, here's the pubic bone, the pubic symphysis. By the way, in the ladies, whenever you have a baby, this has to weaken a little bit, has to be able to separate just enough so that the baby's head can come through there. And if you look back in the back, there's 2 pointy little spines. These are called the ischial spines. That's another chief measurement that has to be made. The baby's head has to be able to get between those 2 spines. If it can't, that may require a cesarean birth, possibly. If we look around back, these are the posterior superior iliac spines, and we say that the joint between the sacrum and the iliac is called the sacroiliac SI joint. That's what we say. Here is the coccyx. Here are the ischial spines. These are the ischial tuberosities. This is what you sit on, and I kind of left it out, but let's talk about this for just a minute. This is called the acetabulum, literally means vinegar cup, and it's the head of the femur that fits up into here. It's very well recessed, very strong, good, very powerfully reinforced joint. In the front, you can see these big windows in the bottom of the pelvis, and those are called the obturator foramen. And of all things, there's only a tiny little obturator nerve that goes through there, nothing very large. Let's look at the femur for just a minute. The head of the femur is quite large. Remember, we learned that the largest bone in the body is the femur. And there's a greater trochanter, there's a lesser trochanter. Here is the anatomical neck, here is the surgical neck. We doing okay over there? Okay. The long portion is called the diaphysis. The transition between the diaphysis and epiphysis is called the metaphysis. This is the patellum. These are called the condyles at the end of the femur. And this is the tibial plateau. This is where the femur articulates with the tibia. This is the tibial tuberosity. This is what the quadriceps tendon inserts into so that you can extend your leg. It's the hammies on the back that flex your leg like this. Now, on the front of the tibia, as we extend downward, this is your shin bone. It's not very well protected by muscle. So if you zonk this on a desk or something, it hurts like a mug. The long bone on the outside of your leg is called the fibula. There is a proximal and a distal fibula. By the way, the distal fibula makes up the lateral malleolus. The medial malleolus, as you can see, is made up by the tibia articulation with the talus. That is the main bone in the foot. As we go into the foot, there is the calcaneus. There's the navicular, first, second, and third cuneiform, cuboid. There are the metatarsals, The tarsals, actually, excuse me, these are the tarsals, these are the metatarsals, and these are the phalanges. And once again, we have the same design in the feet as we have in the hands. We have a proximal, middle, and a distal phalanx in the toes, except for the great toe, which oftentimes is called the hallux. Let's go back to the hand for just a minute. In the hand, we call it the pollex. Pollex, thumb, hallux, foot. Now, something else that I kind of left off and I forgot, I'm trying to come back to it a little bit. But on the humerus, there is a medial and a lateral epicondyle, and a lot of the forearm muscles attach onto this side. There's also a fossa right here. The olecranon fossa is in the back, and I believe the front one is called the trochlear fossa. I may not be saying that right, but I'll look it up and I'll correct it in the video if it's not correct. But it's kind of cool how that because you have these recesses on the back of your humerus and on the front, it allows you to get almost 180 degrees of extension. If you didn't have this recess, you'd probably get extension right about to there. That's about as good as you could do with your arm. But because that bone has a recess in it, it allows you to get to 180 degrees. Isn't that cool? And I would say wonderfully designed. Manubrium, sternum, xiphoid. Notice that the ribs, when they wrap around, they articulate with a cartilaginous articulation here. The vomer bone is in the middle of the nose. I think for right now, that's what I'm going to do on the skeletal system. Maybe later we'll do another one.